Good afternoon or good evening, depending on whether you're joining us from out east or here in Calgary. Welcome to the second CAEP National Grand Rounds for 2021, the fall season. My name is Eddie Lang, and I'm really thrilled to be moderating and taking part in this presentation on leadership strategies that can be applied on a daily basis. We're calling this presentation Epic Physician Leadership, giving a nod to our colleagues at UBC and in the UK who came up with the term emergency physician in charge. We've assembled a great panel of speakers for you today and are planning to leave a good chunk of time for discussions and input from you. So please feel free to send us your questions either by text or by in the chat window. We're going to cover a lot of content tonight. We've got some really great presentations. We're going to be pointing to a lot of materials that you can certainly access and review after the session. I'm sure all of the speakers would be happy to hear from you and reach out, and feel free to reach out. A bit of housekeeping. We're going to have all of the presentations and then leave a consensus or a group panel question and answer session at the end. Send us your questions as soon as they come up so that we can get to them in order that we receive them. And I just want to thank anyone who may have sent in any questions in advance. Our scientific planning committee has reviewed all of the declarations of interest. They're captured here on this slide. You can see that Dr. Patoka and Dr. Crowder do not have any. Dr. Patey has a conflict with Canadian Institute of Health Research dollars for some of the work that he does. And I do educational activities that are sponsored by industry for CAEP, but direct all those funds to the Calgary Health Trust for Research or the CAEP Advancement Funds. So a little bit more about your speakers tonight. I'm Eddie Lang. I'm the department head for emergency medicine here in Calgary. I'm also a member of the board and the chair of the academic section. Really pleased to have two colleagues in Calgary join us this evening. Dr. Catherine Crowder is an emergency physician, works largely at the South Health campus and at the Peter Lougheed Hospital. Prior to the medical school, she worked as an ICU PICU nurse and then practiced briefly as an urban family physician, so has a really wide range of expertise. Her research interests include ultrasound for pediatric vascular access, clinician and learner assessment, and diagnostic protocols for ACS. And more recently, as you'll see from her presentation, she's been studying physician leadership roles. Catherine Patoka is also here and is an emergency physician in Calgary. She's an associate professor in the Cummings School of Medicine, the Royal College program director, and a member of the CAEP board. Her interests are in medical education, resuscitation, and feedback. And has also, as you'll see, conducted a recent realist evaluation of the physician leader role that you'll be hearing more about tonight. Chris Patey is been practicing emergency medicine, family medicine for over 15 years. He's the site chief at Carbonear Emergency for the past decade, and he is brought lots of positive change and initiatives, as you'll see in his presentation, to rural emergency medicine. And he is an assistant professor with Memorial University Medical School in St. John's, Newfoundland, and always trying to get research into practice. So there will be one Mentimeter question coming up shortly, and just invite you to either use the QR code or punch the code into your phone so that we can get a little bit of feedback. So if I can just bring up my first slide for my first section of the presentation. So yes, the emergency physician in charge is a term we've heard from a number of places, including our friends out in Vancouver and in the UK. Next slide. Oh, I do this right. With this. So what we're going to do is focus on three key objectives. We're going to really talk about some of the principles involved in physician leadership on shift while you're working that can hopefully enhance teamwork and mitigate what we all suffer from, which is access block, whether that be getting patients upstairs or getting patients from the waiting room into the emergency department. We're going to take a scientific look at this. We're going to look at some of the previous literature that's come out on the topic, as well as some recent work that we will be telling you about. Really, most importantly, we're hoping that you're going to leave this with some practical strategies that you can even bring onto your very next shift. Why a National Grand Rounds on the topic of on-shift leadership? Well, I don't think I need to explain to this audience some of the challenges we're facing in our healthcare system. I'll point you to two recent, really incisive, instructive CAEP position statements. One on the perfect storm and the challenges that we're facing around the pandemic, and especially amongst our nursing colleagues who along with ourselves are experiencing unprecedented levels of burnout, moral distress, and just the thought of forced overtime and the inability to take vacation is just contributing to the state of morale in our emergency departments. We also know that in a perfect healthcare system, we wouldn't necessarily need as much leadership skills, but in this other report, the healthcare safety net is ripping. We know that there are gaps in primary care, there are insufficient beds in the hospital, and we as the safety net are starting to feel the strains of some of the patients that come to some of the care we provide in the emergency department, be it violence related or patients who may have been better seen in a primary care setting. The impetus for this presentation came from discussions at the Virtual Leadership Series Planning Committee. This is a program that Doug Sinclair and myself have been working on. It ran successfully last April and would certainly encourage you to attend in November. The second session is going to be a more in-depth look of some of the things we're going to be talking about tonight, with involvement from nursing leadership that will be part of that session. So make sure you have a look at that and please join up for the series. So here's the Menti code that I'm going to use to answer to look at the question. It's a pretty straightforward question, and just to give us a sense of who in the audience is already working in an emergency department that has a leadership role. Essentially, what we're talking about is someone who would be in a dyad relationship with the charge nurse, someone who is like the go-to person if there's a system issue that comes up, whether it be a patient with a prolonged length of stay in the emergency department, or a particularly troublesome consulting service, or some other tricky issue that requires attention. And I guess, by working alongside the charge nurse, the idea is you would take these leadership roles and functions and try to, optimize various aspects of emergency department functioning. So thanks to those of you who are responding, we are seeing actually a predominance of people who do not have a kind of a physician leader in charge. Now, I can imagine there may be some people responding who don't have more than one physician working at any one time, and hence you're automatically the emergency physician in charge. But at least for those who have multiple MDs on shift during a single 24-hour period, most of you do not have someone in a leadership role. So thank you for those responses, and I'll presume that's the majority here, and we'll move on. So, at a high level, I think part of the impetus for our talk tonight is the realization that we really are doing a lot more than taking care of patients. A lot of this stems from the CanMeds framework of what being a specialist in emergency medicine is. But realistically, we do a whole bunch of other things to make the emergency department as functional an environment as possible. We look after ED flow, and to that extent, we're traffic cops. We're often, working with our consultants and pitching cases for them to admit. This is something that came to mind when I heard Daniel Pink speak and write the book on To Sell is Human, and how that's integral to who we are as family physicians. And we're frequently in a negotiation mode be it with families or even admitting services. And we need to be cognizant of resource utilization, be that how we manage stretcher space and who we keep on and take off of stretchers, and how we work with our admitting and consulting services to minimize delays and optimize flow out of the department and upstairs. So the science on this is fairly straightforward. The most well-studied role has been called the triage liaison physician. That's different than the emergency physician in triage, but this triage liaison physician role is someone who is going to take the outside calls, deal with the transfer issues, and sort of keep an eye on the overall functioning of the department. And there actually have been 12 studies, much of it led out of Edmonton and Brian Rowe, who have looked at this, and 12 studies, including over 300,000 patients, have shown that although there's variable methods and rigor, left without being seen goes down. The physician initial assessment time goes down when you have a triage, a TLP, but the effect on length of stay is less clear. Two documents, two things to point you to. The International Federation of Emergency Medicine came out with a report on crowding and access block several months ago. And there's a section beginning on page 42 written by David Petrie in Halifax and Ian Higginson in the UK. David couldn't join us tonight, but speaks to these kind of concepts of the leadership roles and what exactly it consists of. And Adrian Boyle and other UK researchers have also published on what an emergency physician in charge does, both, I think, useful reading. Specific to the task force, a report, Dr. Higginson identified 9 chief activities that the EPIC role involves. And it's somewhat straightforward and logical, but for one, you are identified as the physician in charge, and oftentimes trouble will come to you. You don't have to seek it out when there's a bottleneck issue or something developing that's preventing patients from getting in from the waiting room. You are going to be looking along with the charge nurse at solutions. I won't go through all of these. I'll let you look through them, but it involves kind of keeping an eye on things, looking at patients who have been in the emergency department for a prolonged period of time without an admitting service, multiple patients who are waiting for the same consulting service. It's about setting the tone and the culture that there is a go-to person on the medical side of things that can help with difficult situations, help support a junior clinician, provide advice on how to manage a difficult situation, or even know about resources, whether it be community resources that might assist in preventing an admission. Now, again, in a perfect world, we would have the policies and the procedures. All of these may not even be necessary if things work perfectly, but we know we live in a strained and challenged healthcare system, and that these things are not always possible. So that's pretty much it for the overview of the EPIC roles. It's kind of a background context. I will turn things over now to Dr. Catherine Crowder, who will present some of the experience on the emergency physician leadership role that was developed here in Calgary, and we have some really interesting data on that. And we'll get to your questions at the end of rounds, but please feel free to send them on their way. Catherine, over to you.
Hi, Eddie. Thanks for that introduction, and thanks everyone for taking time away from your cognitive burdens and your busy, overwhelmed schedules to tune in tonight. I think this is a really important topic in emergency medicine, and I think this is a really this is an upcoming and important intervention that we can all sort of use in some way in our emergency departments. I have, like Eddie says, I have no conflict to declare, so I'm just going to kind of race past this slide here. So this is a picture, an image of the emergency department I work primarily in at South Health Campus here in Calgary. And this picture was taken in 2013, the day before this department opened. This is a relatively new hospital. And I find this to be a bit of a poignant picture because I sort of noticed the stillness and the quietness of this picture, which is not how I would describe this particular pod in my department at 1 o'clock yesterday morning when I was on shift. This space, a few hours later after it opened, was really a complex intersection of patient care and patient movement, downstream patient movement, staff movement, interactions, and really sort of a busy and bustling space, as I'm sure many of your departments look like. So I really enjoy art, and I kind of like to try to find the intersection between art and medicine and art and life. And this is one of my favorite paintings. And the reason for that, this is a painting by Jackson Pollock. It's called Number 5. And the reason that this is one of my favorite paintings is because it actually, to me, is reminiscent of what emergency department flow is actually like. It's sort of this chaotic picture of movement that's difficult to focus at one spot at one particular time, but when you step back and look at it, you can sort of make sense of it. So I always like to think of emergency department flow less like the tranquil image you first saw and more like this painting. So I'm going to talk a little bit about the physician lead and what some of the on-shift roles of a physician lead can look like. And when I say physician lead, there's a lot of different terms that can be used for a physician lead. You've heard the term EPIC, you've heard the term TLP, triage liaison physician, you've heard the term physician lead, and really they refer to a similar role. The physician lead role will differ in differing contexts and in different staffing situations and different funding models. But in general, the physician lead sort of works with an RN, and it's often a triage RN or the charge nurse, to monitor the waiting room and incoming patients and initiate early investigations and treatments for patients in the waiting room that would be appropriate. The physician lead often will initiate investigations like early DI or early treatments. An example would be, a patient with a clear asthma exacerbation, where it would be reasonable to start a bronchodilator treatment and have that patient symptomatically feeling better by the time they're seen by the departmental emergency physician. Physician leads often can be involved in process interventions as well. And Eddie referred to a number of specific cases, like sort of being the point of contact in the department for access block delays, emergency inpatient delays, and movement out of the department. Often the physician lead will be a part of bed huddle or be liaising with the charge or clinician nurse to look at what some of the delays in moving patients out of the department is. Further, the physician lead can be involved in incoming transfers, that kind of input piece to the department, transfers from other sites, EMS patches, potentially critically ill patients coming in, and help to deploy not only their own staff, but also some bed movement to facilitate those transfers and those higher acuity patients coming in. Finally, the emergency physician, amongst other roles, can help with facilitation of disposition, and Eddie referred to this as well. One of the examples being, mitigating conflict or multi-consultant patients, sort of that patient where internal medicine has been consulted and potentially they're sick enough to go to the ICU, but not quite sick enough to go to the ICU, and ICU is involved, and sort of this back and forth. Often the physician lead can get involved in these cases and help facilitate a more expeditious disposition for these patients. And another good example is the physician lead getting involved with medical clearance in mental health patients. Many departments across this country use serial clearance rather than a parallel clearance for mental health patients. And so sort of screening these patients for ingestions or intoxication up front, so that potentially these patients can be medically cleared to be assessed by the mental health team in a more timely manner. So when we kind of look at what the role of the physician lead is, we kind of have to ask ourselves, what is the objective of having a lead physician in the department? And really, we have to ask, what do you want the physician lead to do for your department? What impacts do you want to see with a physician lead working in your department? And arguably, as Eddie mentioned, flow would be a number one sort of impact to evaluate in the physician lead role. And this has been evaluated by a number of research studies that Eddie has alluded to in his introduction there. But primarily, ED length of stay is an important flow measure that can be evaluated with the implementation of a physician lead. Further, physician initial assessment or waiting to be seen time can be evaluated. Stretcher utilization in the department can be evaluated, and these are all sort of metrics that can be collected and evaluated in an objective manner. But I think one of the most important things that can be evaluated when a physician lead is working in your department is EMS length of stay. EMS cruise waiting, or as we refer to it in Calgary, EMS park, is really sort of this risky area where patients who are more likely to be of higher acuity, more frail, more likely to be admitted, arriving by EMS are sort of in that waiting to be seen line and have the potential for higher acuity. And often there's some difficulty getting these patients into beds in the department. And further, EMS units are sitting and not on the street while they're waiting for beds in the department. And the physician lead can be a really helpful resource in the movement of these patients into the department and freeing up EMS units back to the street. There's some other measures that I think are important to evaluate, and some of these measures I sort of have termed care-focused measures. And really what I'm referring to are time to treatments and time to investigations. That asthmatic patient that I mentioned certainly can potentially be feeling better with bronchodilator treatment earlier in the course of their ED stay. And time to consult is also an important measure, and in looking at the overall flow through the department. If we have identified that sick pancreatitis patient that needs to come into internal medicine and spoken to our internal medicine colleagues sooner, there's potential for reduced ED length of stay overall for that patient, reduced stretcher utilization, reduced bed utilization, and better movement through the department. There's also some care-focused measures that are sort of more anecdotal that we can look at when it comes to physician lead involvements in patients' care. And a lot of the examples I've received over the years of physician lead involvement in Calgary is sort of more anecdotal, like using point of care ultrasound at triage to pick up that ruptured ectopic pregnancy that's sitting in the department that needs consultation, needs, blood work, needs stabilization. Or picking up sort of subtle findings of a patient who may have an intracranial hemorrhage in the waiting room and initiating DI investigations sooner to pick this up and to disposition these patients to definitive care. Safety measures have always been talked about when we talk about implementation of a physician lead, and some of the important safety measures would be, of course, left without being seen rate. As Eddie mentioned, universally, physician lead involvements in departments have decreased the left without being seen rate. And of course, ED readmission rates, so ED bounce backs or revisits or bounce backs with admission to hospital can be reduced or can be affected with the involvement of the physician lead. And lastly, and arguably, I think one of the most important pieces of evaluating a physician lead is really what is the experience of providers when there's a physician lead in the department. And by providers, I'm really saying that quite broadly. The physicians working on shift in the department who are not acting as a physician lead, or the physician leads themselves, what is their experience with this role? Of course, the RNs, including the triage nurses, the nurse clinicians, the charge RNs, what is their experience with physician leads, EMS consultants, all of these multidisciplinary team that we work with in the department can be impacted by the presence of a physician lead and the work of a physician lead. Some of the things that I think are important to collect feedback on for our physician lead role, if it's implemented in your department, are what are the providers' experiences of optimizing throughput in the department? Is their experience in keeping with actual optimizing throughput, or were there unexpected access blocks that occurred despite the presence of the physician lead? Was the physician lead a resource to other staff? As Eddie mentioned initially, sort of acting as a resource to more junior staff or to residents or working with consultants where there's disposition delays. what's the impact on the workload, both for the physician lead and other staff working in the department? And not necessarily directly, but what is the provider's impression or reports of the patient experience when a physician lead is present? These are all important things to consider when looking at implementation of a physician lead in your department. And so at this point, I'm going to pass the baton to Dr. Catherine Patoka, and we will take questions at the end of rounds. Thank you.
Thank you, Dr. Crowder. I'm very honored to be speaking to you about EM leadership on shift this evening, but I thought I would start by outlining why it is that I'm here talking to you about this. So in my 8 years of practice, I've become quite skeptical that evidence-based medicine will present us with a simple fix to the complex problem of care delivery in the overcrowded ED. And in exploring that skepticism, a group of learners and I undertook a realist evaluation of the EPIC leadership pilot project described by the previous speakers, termed the EPL, or Emergency Physician Lead. I plan to share some of the lessons learned in hopes that it may help those of you considering your own implementation of such a role or intervention. With that in mind, I would like to acknowledge that my comments and thinking have been greatly influenced by the team of scholars acknowledged at the bottom of the slide. So Tess Locke, Zoe Polsky, Jason Elzinga, and Rachel Ellaway have all informed my thinking. And for that, I'm greatly appreciative. So my goal is to try and highlight what we know about the EPIC roles and also what we don't know. Those of you that are familiar with the film The Matrix may recall the scene where the main character is offered a choice between a red pill or a blue pill. These terms refer to a choice between the willingness to learn a potentially unsettling or life-changing truth by taking the red pill, or remaining in contented ignorance with the blue pill. The following 3 slides will demonstrate 3 fictional implementations of the EPIC, with dialogue formulated in the form of a blue pill and a red pill. So to kick it off, our first fictional ED is the Trinity ED. It implements an EPIC and conducts a well-done, methodologically sound RCT and identifies that the ED length of stay decreases by 30 minutes with the EPIC implementation. Wow, what a blue pill. So the unsettling red pill truth is that the ED length of stay gains were largely through the EPIC seeing and rapidly discharging CTAS-5 or lowest priority patients, while leaving CTAS-2 patients in hallway beds waiting. On evaluation, triage nurses highlight frustration with the role, as it is prioritizing the care of patients who have a lower risk of adverse events and are felt by many to be justified in longer wait times. Moving on to our second ED, the NEO ED, which also implements an EPIC. In this implementation, EPIC physicians are instructed to ensure there is early lab and diagnostic imaging and management orders. The subsequent data pull from the EMR suggests that indeed time to first test ordered is decreased across the board. Again, a blue pill. Our deeper evaluation reveals frustration among emergency physicians who see a disproportionate amount of patients who have what they term inappropriate tests, such as D-dimers and CT scans ordered. Furthermore, nurses are frustrated because there are now tests ordered on every patient, even those in the waiting room in the hallway, and there are no RNs to fulfill those orders. Another red pill. Finally, we have our third ED, the Oracle ED implementation. The stated goals and objectives of this implementation were to improve collaboration between the triage nurses and ED physicians. It was sold as an MD at triage who could inform some of the complex decision-making that happens there. The red pill of this implementation, sadly, is that most nurses felt that they could rarely find the emergency physician in charge. They had no way of reaching them, and as such, they too are frustrated. So obviously, I've chosen these illustrative examples intentionally to demonstrate some of the less desirable potential impacts and outcomes of an EPIC. But I'd like you to keep these examples in mind as we re-examine and interpret some of the key results of the systematic reviews that Eddie spoke about earlier. So the 2 major outcomes noted in the most recent systematic review in 2020 by Ben Abbas were changes in ED length of stay and decreased left without being seen rates. And those outcomes were similar in the previous systematic review by Holroyd et al. The change in ED length of stay, as Eddie mentioned, was quite heterogeneous and in fact not subjected to meta-analysis, with the authors instead quoting changes ranging from a decrease in ED length of stay of 82 minutes all the way up to an increase of 20 minutes. The left without being seen rate did, however, see some gains with a risk less than 1 in the intervention group. What I hope the 3 previous examples and these results highlight are 2 things. Firstly, the outcome measures we've seen from the current data do not provide us with insight into how these reductions were achieved. And secondly, there was a substantial amount of variability in the impact of the EPIC. Specifically, ED length of stay could have been up to 20 minutes longer in the presence of an EPIC. So perhaps the reality of EPIC implementations is that some of the red pills in our examples could have been at play. In my mind, what it comes down to is that interventions like the EPIC are complex. What this means is that they don't have a linear causal pathway, and their outcomes depend quite a bit on the choices made by their human actors. So complex interventions present the greatest challenge for evaluation and for utilization of evaluation because the path to success is so variable and it cannot be articulated in advance. The way most researchers have chosen to look at interventions like the EPIC is to start with an implementation, ignore the black box of activity that happens in between, and then look only at very specific endpoints, not acknowledging what is in the middle. If you look at that black box, and we might see something like this, which looks a little bit like that picture Dr. Crowder showed us of just these arrows going in every different direction. By leaving out these factors, including other outcomes, implementation context, concurrent programs, characteristics of patients and providers, some of these simple and linear models risk overstating the contribution of the intervention and may provide less information for replication. To understand why there's inconsistency of outcomes, we need to ask the rather different question of why or how the intervention has its effect. We need methods that seek to understand how the program actually changes behaviors and why not in every situation. So where do we go from here? When considering an implementation of a complex intervention like the EPIC, there's a few practical tips I can leave you with. You need to think about your context. Just because we see promising data out of Calgary or any other center does not mean that it's going to have the same effect in your context. This is even more true since many of you will be from rural or community settings, and what works in Calgary may not work in your shop. Secondly, you have to have clear goals for what you intend your intervention to do, and you should consider the mechanisms of how these are going to be achieved. Rather than focusing solely on desired outcomes like decreased length of stay, focus on the underlying mechanisms, and that may help you in the end adjust your intervention as you proceed with your implementation. Finally, you need to have a clear monitoring or evaluation plan to ensure that your intervention is working as you intended, or more realistically, to be able to interpret what your intervention is actually doing and make adjustments that make it more successful. I certainly hope that my cautionary tale doesn't dissuade you from attempting to implement an EPIC in your ED. I just hope that it makes your expectations more realistic. Thank you. I'm going to pass it over to Dr. Patey now.
Great, thank you very much there, and very honored to be here at giving this talk today. So I'm just really going to give it a kind of a lead thing, an approach to leading a rural ED to minimize access block. And I think more of from our perspective in a rural emerge, it's really giving some practical advice. So just to put things in perspective here, so some rural context. I'm in a semi-rural kind of emergency department that's 90 minutes to a tertiary center. We have one ERP on at all days, and we also have some nurse practitioner mid-level coverage from 8 to 4 on every day. Plus, we have our double coverage that comes in. We call them the hero, where they come to save the day, and that's 8 hours a day to 6 hours a day. So it allows us some time to really recapture and regroup. And as a rural department, we have gone through 5 years of ED flow process overhaul. And it has been quite an interesting sort of transition for us, to the extent where our PIA has gone from 120 minutes to 35 minutes on average, and our left being seen is from 12% down to 4%. So there's been some drastic changes, and I will say with that, there's been an increase in the amount or volume of patients we have to about 50% more. And that's where the hero shift came in to help with our volume increase with our times. And I will say we're the only architecturally designed triangle hospital in Canada that I know of. And that guarantees that we have lots of lost patients and pretty much a lot of confused carpenters who are trying to get angles and get patients into corners. So it is an interesting place to work. So the question that comes to me, and even when I speak to learners and stuff coming in, how do you move from an independent emergency room physician, kind of has a patient sitting in front of them, and you kind of have to give that quality focus on that one patient. And you really look at that and go, okay, do I just focus all my time here? But one who also has an eye on all those who kind of sit behind the first that you see. You know, if you're not processing the first, you put all that quality time, you spend 2 hours with a patient. What about those 10 patients that are sitting behind that one when you kind of probably should be darting out to see as well? And I think from our perspective, the situational awareness is key, and it's a learned behavior. And I think it can be taught as well. And if we're not practicing teamwork in this situation, then it's very hard to move forward in these departments. So what do? First, when I walk on a shift, I kind of look to the flow or charge nurse. This is Paul Norman, who I work on a regular basis. And as a nurse, we have back and forth kind of how we flow patients through. But I look to that charge nurse and I say to him, how's the department running? I want to kind of a sense of how the department is. I want a sense of how other nurses are on the staff. I want a sense of what's going on and get that relationship going early in the shift. And then I kind of look at them and I say, well, where's our momentum forward? We're at 2 o'clock in the day. I've just come on a shift. It's really full. How do we move forward, and how we do that as a team? And I think that kind of lead position from a physician and lead from a nurse, when you get that collaboration going, it really does allow emergency departments to move forward. And then I kind of swing with the flow nurse, and I'll go to what we call our command center. Now, obviously, it's not like your command centers and large academic centers. However, we do have a sort of a patient tracker board now, which we can see patients that are in our departments, patients that are waiting in the waiting room. And also we're still ink based, so we're doing paper charts. But that allows us to really get a good feel. So we'll process this. We do what we run the boards. And I run the boards with nurses, with physicians to find out who's in the department, who's going home, who should be going home. And in the same process, we'll complete our surge protocol to see how busy we are and report that out to our departments beyond. And from that, we gain this department and hospital-wide flow awareness. And department and hospital-wide is always difficult because we always come to the point where people wonder about hospital-wide flow, and we have all these patients here, and why can't they move them up? But I really want to focus in on that departmental flow. I'll then step back and I'll kind of look at who's my co-ERP, my co-physician, and my mid-level team that's sitting there. Nurse practitioner Sue Snellgrove on the right here, a big key part of our department. And I'll attempt to touch base with all those members. So kind of walk in, see how things are going, see how they're feeling, how things are working out, and knowing how well they can move forward and process patients during the day. And I'll at the same moment, ensure the least amount of siloed work, so that we are trying to process the department as a team. And then I even look to our learner assignment. People often wonder, if we have learners who are generally slow, and the evidence doesn't show that. If you use learners effectively, your department can move quicker. And so I talk to them, what do you really need? What are you looking for out of this assignment? What are you looking at being here? How can we move you to process patients that you get your learning, which is key, and that our department doesn't bog down because of some of the practices that you are not otherwise aware of. And I kind of think about educating them as well to a flow mind. How you flow patients through is, again, it's something we have to teach our learners so that we can get patients through our departments. And when we run to differential diagnosis and we run to our plan, I think it's terribly important that they put disposition as a key point on their presentations. And I focus in on that with the learners. This is a great thing that passed over on social media recently by Hans Rosenberg out of Ottawa. And it really does step to some of those ideas about how we educate our learners for EM rotations. And that was on Twitter, and it is a great source. And I actually had it posted in our department so that learners have the opportunity to really think about how they're going through, not necessarily look at that patient in front of them, but also the department, how they function in it. And then I kind of move to operational tasks. So can I advance patients waiting for consults? So do I really look at these consults, say, are they not here now? Why aren't they here? Try to work that. And I also move to the inpatients that we have. And we all have boarded patients at our department, but there's some steps that I can do to advance that. Then I question if our super track is moving. And in our situation, we have a super track which has what we call non-sticky beds, where we can put patients in. They are seen there, but they never stay there. So we're constantly have a position to assess patients. And that would be our RAS center, or our RAS approach, or flow center is what we've adopted to make sure that we have good flow through departments at all times, even in the points of being in overcrowded situations. And then can I go to, if it's a big surge, it's huge and patients continue to file in, can I go to triage to move some ahead of that surge? Can I really get in front of the door to knock down some of those long waits for individuals as we continue to catch up? So I think putting patients truly at the center of care will also guide ED flow. If you kind of look at these patients and you think, where if they were your family members, and would that be someone, is that the way you would want them treated? And I think where the waiting room patients are everyone's responsibility. So we often are left sometimes with triage nurses who have 30 patients in the waiting room who've never been assessed by a physician or a nurse in the department. And that is a burden on the triage nurse. So we really want to try to make sure those waiting room patients are everyone's responsibility. And I think where they receive care you expect for a family member, and in our department, which is a smaller rural department, sometimes they are family members. And if we're not providing the care that you expect for your mother who's arriving through the door with chest pain, then we really got to look deep and see how we can remodel or reprocess this to bring people through the system. So just to recap here, some rural ED leader concepts for me. I kind of look at individual as I come on a shift, gain that global situational awareness. Then I look towards a team, learner, mid-level, or other ERPs that are in the system, find out where they are in their sort of day. Then the operation, obviously critical comes first. Then my triage and the super track, and then triage and working down through those systems. And asking, are the patients the center of care? Is there someone who's sitting in our waiting room for 10 hours in a wheelchair who's not received a lunch? And I think when you start looking down, diving deep at that level, you'll start to lead ED flow, and people will start to follow that as a key role model in the process. And this is where we look at leading ED flow. And there really is a point in a shift where you kind of sit back and go, God, we're swamped. And I think we're all in those situations more recently, that is there something that we can do here to keep guiding that process? But thank you. And if you reach at any point, if there's any questions at all, and I'll pass the baton back now as well.
A huge thank you to you, Chris, and to Catherine for really nice, balanced presentations about the leadership role and what we've learned so far. We have a couple of questions that have come in looking for a bit more information and detail on the emergency. The role we've called here in Calgary is the emergency physician leader. And I'll just give you a bit of quick background on it to put it in context. Calgary is a fee-for-service setting. And it was, I think, in 2017 that the zone convened a major meeting with about 60 healthcare leaders in Calgary to tackle the problem of what we call here, as Catherine Crowder mentioned, EMS Park, which is the ramping or the offload delay for EMS. And the exercise was to come up with projects, proposals, ideas that would have hopefully the greatest impact on this problem. And the idea of the EPL was one of the ones that bubbled to the top and received specific funding to make it happen. Because in developing the role, we felt strongly that if at all possible, the leadership role had to be kept distinct from the direct, most physician responsible kind of role, and that you couldn't be the one who would be interrupted when issues arose or had to sort of have that situational awareness that Chris spoke about. You couldn't do all these things well and also be following patients, although I recognize that, Chris, you probably have to do that all the time, being the solo doc in your department. So, we have in Calgary at the foothills, for example, as many as 14, if not more, shifts every 24 hours. And I think we made the case to our colleagues in Calgary's own leadership that a coordinating role would be helpful and that this would require special, unique funding. We also launched the EPL as 2 shifts per day. We wanted to protect quality of life, so we made it weekdays only and had one of the EPL shifts start at 7 a.m., the other one start at 2 p.m., and there could be a brief sign over between the two. They were 7-hour shifts. And we kind of look back on that and look at some of our data and wonder whether a later start would have been more valuable, as that's when some of the bottleneck and flow issues come into play. So those are questions from Ken Chan out at UBC and Laura pitching in. I hope we got those across. So it did require unique funding. It did not work in a fee-for-service model, and it is not currently in place, although we're looking at reinstituting it because although we had some positive metrics, it was not felt with the financial strains that AHS was under at the time to be something that could be prioritized for that would be an ongoing effort. So I hope Ken and Laura, that answers your question. Catherine's, was there anything you wanted to add to those questions about how the EPL shift, which ran for I think a total of 6 months at 2 hospitals, how it played out and some of the other considerations?
Thanks, Eddie. I think you sort of captured the vast majority of the important points there. And I would add that in the spirit of Dr. Patoka's talk, there's always sort of a balance when you're looking at scheduling an additional physician to the department without augmenting the physician manpower or sort of offloading schedules as a departmental MD. So some of the feedback, looked at what drawing from to staff 2 additional shifts per day for physician leads. And so that's one of the considerations is if you have a physician that is acting in a physician lead role, it's worthwhile to consider what sort of manpower needs you may have in your department to cover those additional 2 shifts per day. In our case, 2 shifts per day, but can be variable based on the department you're working in.
Awesome. Catherine Patoka, did you want to add anything?
I guess the only thing that I would add was also just in the Calgary model, it was more senior physicians that were selected for the role. So they were at least 5 years in practice with some kind of demonstrated leadership role. So that's how the decision of who would staff those roles would be. And I think it's really important, even the comment that you made about the timing. It's not so much you're going to introduce something and it should probably be relevant to your context, but as you gain knowledge and see the implementation, so we saw 2 implementations back to back at 2 separate sites, I think you're going to make changes on the fly. And I think that's a really important point, that whatever you introduce is going to have its downsides and its upsides, and you want to try to maximize the upsides and decrease the downsides.
Fantastic. Chris, I've got a question for you about the concept of being able to teach these skills, the situational awareness, the ability to, fulfill multiple roles at the same time. You're not only taking care of patients, but you're keeping an eye on the overall flow of the department and checking in to see where your investment can have the biggest return. Could you be more specific about how do you actually do that? Is it SIM? Is it something else?
So it's a great question. And from our CIHR, there's no existing educational formats now for teaching flow. It's really a top-down kind of phenomenon, which you learn on the ground and kind of say, well, this is how we get it. Through our CIHR research project now, we've actually just completed a systematic review of what's important in an ED flow course. What would be needed, or what do we think we need to teach to residents, to physicians on the ground for that manner? And funny enough, the number one of our top 10, the number one that came out was teamwork. People were saying we need to teach teamwork in these environments, and I think that speaks back again to this epic, this idea that that there's someone on the ground that is leading a team, but realistically, there are no courses, and hopefully with the CHR, we will continue to develop and maybe get a course out there that teaches these concepts that need to be there early rather than late.
That's awesome, Chris. And I don't know if it's something to consider that might be opposed to what you just said, but I do know that the McMaster group has come out. It's different. It's not about teamwork. It's more about maybe processes and flow. But there is that gridlocked with ED at the end capitalized board game that has been developed there. I believe Teresa Chan led that and has been at least used to help teach residents, if I'm not mistaken, some of the flow principles. And there is a history of some educational efforts, but I agree, the kind of thing that you're talking about is very much wanting in the emergency medicine educational scene, and needs to be developed. I have a question that really could be for any of you. If you wanted to pitch, this is from Greg Shiner, if you wanted to pitch to your hospital leadership an investment in this role as a physician leader, what tactics would you take? And Greg, if you want to reach out, we can share the slide deck that we use to make the case. But in broad strokes, and Catherine Crowder, perhaps I'll start with you. What would your thoughts be? If you had a few minutes to pitch this to the executive director of the hospital to get an investment in this, if it were feasible, what would some of the key issues be that you'd bring forward?
That's a really great question. And I think probably the most relevant response would be that it depends on what your objectives in your hospital and department are, and what your need is in your hospital or your department. Whether the overarching issue that you're facing in your emergency department is access block or bed block or flow issues, or whether there are concerns around the safety of patients waiting in EMS park and outcomes for adverse outcomes for those in the waiting to be seen lineup. Regardless of the flow in your department, it really depends on what your objective is for your individual department. If it was me making the pitch for funding, which we all know is can be few and far between in the state of our current healthcare funding models, I would look at a combination likely of both. I would look at some of the literature that does support improvements in length of stay, improvements in physician initial assessment time, improvements in left without being seen rates. But I would also look at some of the patient safety reviews, where intervention sooner could have made a difference in the patient review. I think those are impactful features to present to hospital leadership. But again, it really depends on what your specific local issues are and what your objectives of implementing a physician lead type role would be in your department.
Catherine, Chris, anything you'd like to add?
I guess the only thing I would add is that, and Eddie, you could probably speak to this locally, is that really I think the pitch was successful in Calgary because of two issues, flow and safety. So I think you guys did a really good job of outlining some of the dangers of EMS Park, and there was a very good reporting system that allowed you to have access to some of the unfortunate outcomes of wait times in that EMS Park, and that is my impression of what really pushed it to our pilot in Calgary. But apart from those two things, the third thing you should consider is just that teamwork aspect that Chris will probably talk about a little bit more. But we saw a lot of really positive comments from, despite some of the negative things I outlined in my presentation, but we did see a lot of positive comments from our nursing staff about the collegiality and the ability to work with someone, bounce ideas off of them. There was this feeling that it was really a team sport at triage, kind of helping with issues that in our siloed emergency department, where physicians are kind of more focused on individual patients, that was very appreciated.
Chris, would you like to weigh in?
Oh, just one point. I think the amount of stress I think we're all providers in emergency departments right now. If we have someone in line that's taken any of that stress off at any point, if you want to sell that to a hospital board, administrative board, that you have nurses that may stay and you have physicians that will want to work more. And I think that'd be a big sell for me if you can put someone in there to actually decrease that burden.
Those are great comments. I'm just maybe going to round it out by saying that I think our pitch was made predominantly in 3 areas, and not all of them were evident until we got started. I think one was the patient experience. So when I took some of these emergency physician leader shifts, and when I'd go to a patient and say, "Hi, I'm Dr. Lang, I'm not going to be your emergency doctor, but I'm here to see if there's anything that to assess you and see if there's anything that we need to maybe get started early on you, whether it be a treatment or a test." The usual reaction for someone who's already been waiting 2 to 3 hours is or less, but is the face kind of lights up. So the idea that you can kind of get in there and hopefully order appropriate treatment investigation upstream before there's a dedicated physician to put it all together, I think is quite beneficial. I think staff morale is the other big area, because I think often the physicians did appreciate being able to get to a patient where key investigations and treatments were already initiated. They had perhaps already stopped vomiting, or the diagnosis from the chest X-ray that required physician ordering was already there, and that aspect of it. And providing the nurses with a go-to person. I remember being called in to see a patient who was still probably an hour away from being seen, but who was starting to present psychiatric agitation and mental health concerns. And a physician needed to intervene right away, I think, with a sedating order that was not easy for the nurses to do if it hadn't been for knowledge that, yeah, there's one doc on who's there to be interrupted, and if you can find them, get involved. And then, of course, as I think was mentioned, is the patient safety issue, whether it be to get some key investigations going, or to troubleshoot a difficult problem before it spirals and becomes a worse one. So I think from those 3 vantage points, we were able to make the case. Great. Well, if I'm wondering if we've got just 1 or 2 minutes left, maybe we'll use this to kind of close things up and see if there's some final thoughts from our panel. Wanted to also thank everybody I know these are crazy times, and our healthcare system and our emergency care systems are under a lot of stress. Really appreciate people who joined us tonight, and wanted to thank all of our speakers and panelists for doing such a great job. It's not a black and white affair, the emergency physician lead. I hope we were able to present both sides of the coin and have provided you with some thoughts going forward, some things that you can do on your next shift. And please feel free to reach out if you're looking for some additional literature and resources. We'd be happy to share. Any final words from our panelists? Chris?
No, I think you summed it up just lovely there, Dr. Lang.
Thank you. Catherine Crowder?
Hey, thank you very much for moderating this, and thanks everybody for joining us. I think it's a really important topic that we need to be talking about a little bit more, and making steps in our individual departments towards improving flow and patient experience and access. I'll just add that I'll add my email address to the organizers with CAEP, and please feel free to reach out if you have any questions about sort of local implementation and some of the literature background. I'm happy to touch base with you and respond. So I'll just add my contact info to the slide deck.
I just want to echo what the other speakers have said. Thanks for the opportunity. And it was really great to hear the other presentations about some of the other stuff that's going on around the country. So thank you very much.
Thanks, everybody. Just one last minute message coming in from Sophie Gosselin in Quebec, which reminds me of my days at the Jewish General Hospital in Montreal, where we had a flow doctor on who did not see patients primarily, but was really involved with troubleshooting the patients that were kept overnight waiting for their CTs. So it looks like there are precedents, and I'm sure Sophie would be happy to share the job description. In fact, that's exactly what she wrote in the text. So thanks very much, everybody. Thank you, CAEP. Thank you, Jeff Allen, for putting this all together. If you missed it or you want to share, I'm sure the archive will be available and hopefully will be of use to CAEP members. Thank you. Have a great evening.